Well, we decided that swallow isn't safe, and now we need policies to allow them to eat and drink despite our advice. Nobody else works that way, and I don't go around having policies for taking warfarin at acknowledged risk of bleeding. I'm qualified quite a long time. That is only crept in the last 2 decades or so. There was none of this 20 years ago. The staff in the units used common sense. They didn't use thickeners. Speech and language therapists as pneumonia busters, the diet police. We decide what they're allowed to eat and drink based on essentially our anxiety about aspiration.
So where does this research come in?
Dysphagia Research Bites.
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speechies, especially those working in home and community-based settings. My name's Chantal, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. We're joined today by Dr. Shaun O'Keeffe. He is a consultant geriatrician at Galway University Hospitals and an honorary personal professor in medicine at the University of Galway in Ireland. He is a national clinical lead for the Irish Health Service for Consent and for Mental Capacity Law, and his research interests include dysphagia and ethical issues in the care of older people. And he's joining me to talk about the topic of risk feeding, also known as eating and drinking with acknowledged risk. Welcome, Shaun.
Glad to be here, Chantal.
Now, one of the issues I think in regards to risk feeding plans is that traditionally we've had a bit of a misunderstanding in that we've thought that aspiration equals aspiration pneumonia. Now, I think these days I'd like to say that most therapists maybe understand this isn't the case, but do you think that's what has sort of contributed to maybe perhaps a higher number of risk plans being developed than is warranted?
Yes, I do. I think that a lot of this is about language, and it's not just semantics. It's you put down aspiration, and immediately you're thinking Prandial aspiration. Why? And it's banal, but every pneumonia is just about everyone is aspiration. It means you're getting bugs in the oropharynx heading for the lungs and doing damage. That's pneumonia. That's the nature of it. So why the obsession with food and fluid? And it doesn't make any sense. And every time people hear aspiration pneumonia, you're thinking, oh, the speech and language therapist should have prevented this by doing something to diet. No, and that's, first of all, it's kind of arrogant on terms of speech and language therapists, and it's also a rod for your own back in that we're the pneumonia busters. We can solve pneumonia. And of course, you can't solve pneumonia. Pneumonia is just a condition that people get and are more likely to get when they're frail. So when the terminology sends you off in the wrong direction immediately in terms of saying this is something that's preventable by doing something with food and fluid. Whereas I think the terminology David Smithart, who's long published in dysphagia, suggested just call it the pneumonia of frailty, which means that older people who are frailer are more likely to get pneumonia. And that's how a lot of older people die, for example, with dementia. And it's not that anybody doesn't want people to avoid pneumonia, but the idea that you can stop it by messing with food and fluid has never been shown. So the idea of pneumonia busters doesn't work. And it leads to an enormous anxiety, I sense, among speech and language therapists. And that's what the whole risk feeding idea, oh my God, they might get pneumonia, I'll be blamed because I let them eat and drink. I allowed them. I said they had a safe swallow, and it's on me Therefore, we need policies and signatures. We need massive anxiety about this. Whereas you don't get physiotherapists looking for policies about risk walking. We know, for example, nobody will fall if nobody moves. But that doesn't mean that they're filled with this anxiety about getting people to sign forms and countersign it and what will happen if they fall. You do the best you can. And unfortunately, people are going to fall and people are certainly going to get pneumonia, whatever you do. And I think the whole idea of these policies is entirely misplaced. And you're right, it comes back to this idea of aspiration pneumonia, meaning prandial aspiration causing pneumonia.
And it sounds like this fear and anxiety is not just within speech pathology, which I thought that it was. It sounds like it's in other fields as well. Well, obviously, you've written this paper based on those guidelines, because I can definitely speak from experience and from chatting to my colleagues. We do definitely come out of our programs with a fear of aspiration and a fear of aspiration pneumonia.
Well, it's the idea that one drop of water in the lungs and it'll explode, which isn't
Yes.
the case at all. You're right about other fields, but I think they've been, and this sounds terrible, contaminated by speech and language therapists. What I mean, particularly, you're talking about nurses, and the one we've been looking at most recently is in the residential care facilities. They don't have access to speech and language therapy and proper swallow assessments, but
Mm,
they have this fear as well. And their first thought is, well, they have trouble swallowing. What would a speech and language therapist do? Oh, I'll puree the diet and I'll put them on thick fluid. And they do it, and they do it with the best of intentions and well-meaning, but it's absolutely horrendous implications for patients. So it's out there that this is what we do to prevent pneumonia, and we can't be
mhm.
criticised if we put them on puree and thick fluids, usually really thick fluids, and we're doing a good thing. And that's widespread. We've shown it in Ireland, and I see colleagues in the US have shown it's extremely widespread that nursing staff in these facilities will automatically modify the texture of diets in response to any perceived problem with swallowing.
And I want to go back to what you mentioned about prandial aspiration. Can you explain why, for example, let's say someone is aspirating on thin fluids, but not on thickened fluids, so we'll put them on thickened fluids, or perhaps we'll make someone kneel by mouth. Why isn't that likely to eliminate the risk of aspiration pneumonia?
Well, because as you know, we swallow saliva probably 1,000 times a day. And if you're not able to swallow safely, then you're not able to swallow saliva safely. So the saliva is going to slip down. It's more harmful to lungs to have thick material going into the lungs than non-thick material. Uh, and only recently have we ended up with the animal studies looking at this because, of course, thickeners are not regarded as a medicinal product, so they've never gone through the kind of rigors that a medication would go through. So the oropharyngeal material is going to slip into the lungs if you're not swallowing, and that's going to happen multiple times a day. It's not simply about eating and drinking, and I'm afraid that's not going to be fixable because, and it's a vicious cycle. If you try and restrict somebody's saliva, you could dry up their secretions. They'll end up with a dirty mouth and end up with even
Mm.
more material going into the lungs. So it's just an issue that isn't fixable that way. And I know you're interested in one of the other papers, but an awful lot is to do with the person and their frailty levels and their immune system and all of this as to who
Mhm.
can cope with the material and who can't cope. But remember, whatever you do with food and fluid, saliva is still heading in that direction one way or the other.
Yep. Um, yeah, there is a paper that I wanted to ask you about. I'm not sure if you're aware of it. I think it was published maybe the year after your paper was published. And I think since it's been published, I feel like we're doing a better job in this area of not being so hyper focused on only aspiration, and we're thinking about it more holistically now. A paper that's been published is called, I can't remember the exact title, but they present a framework called the BOLUS Framework, and it's just based on all of the existing literature talking about, the risk of an adverse event in someone with dysphagia. Have you heard of the BOLUS Framework, Shaun?
Yeah, and it's the trouble is it's a very nice paper in some ways. It collects an awful lot of good information
Mm-hmm.
about it, but it suffers from the same problem. It's it take the risk factors they discuss are risk factors for pneumonia, and
Mm-hmm.
it conflates that with prandial aspiration, and it's
Mm-hmm.
again an adverse event in dysphagia, and it's implied that the adverse event is in some way due to eating and drinking. And it goes back to my patient's swallow is safe to allow them to eat and drink despite their aspiration. Hold on a
Mm-hmm.
second. That's not the point. So yes, absolutely clear that somebody who's immunocompromised and who's frail is more likely to get pneumonia. But what's that to do with eating and drinking in particular? And it is very much saying that, oh, if they have multiple risk factors, then their pneumonia is going to be a bad one. Therefore, now I can recommend restriction of eating and drinking in some way. Well, how's that going to work? And it goes back to the idea of speech and language therapists as pneumonia busters,
Mm-hmm.
the diet police. We
Yes.
decide what they're allowed to eat and drink based on essentially our anxiety about aspiration. So, the actual detail contained there is absolutely excellent about risk
Mm-hmm.
factors for pneumonia, but they're not risk factors for pneumonia due to eating and drinking. They're risk factors for pneumonia full stop. And
Yep.
it does end up going an acceptable level of risk. Really, you can't prevent pneumonia. So the idea that you're going to restrict eating and drinking and decide if somebody should be nil PO uh, doesn't work. And it is looking at life in isolation. You make them nil PO, that's great. So what next? How are they going to get nutrition and fluid?
Mm-hmm.
And you can't just say, "But that's not my problem. I've just decided they're nil PO." Now you sort it out. There's no good tube feeding doesn't work in dementia, for example.
Mm-hmm.
You want everybody on tube feeding, uh, or you want more risk feeding policies. And well, we've decided that swallow isn't safe, and now we need policies to allow them to eat and drink despite our advice. Nobody else works that way. And as I say, that's not how it works with physiotherapy and walking. I don't go around having policies for taking warfarin at acknowledged risk of bleeding, and that I need a whole policy for that. That simply stuff happens, and it's not an adverse event due to eating and drinking.
Mm-hmm.
It's just one of the complications of life. People get pneumonia, people get urinary tract infections, people get other things. So by
Mm-hmm.
all means, deal with modifiable risk factors. But the idea that you can use that framework to say, well, I've determined they're at really high risk of a bad pneumonia, therefore they can't eat and drink as they wish. Where does that come from? And what's your evidence of benefit from your interventions?
I really like this quote from your article. It says, risk is meaningless without reference to a specific adverse outcome, the likelihood it will occur, and how severe the impact is for an individual. Um, and, we've touched on a bit of this. And I guess the issue is that we don't have all of this information. I know we can specify what the particular adverse outcome might be, and quite often we're focused on aspiration pneumonia, or maybe choking, but we can't really state how likely that is to occur, and we can't really state ultimately how severe it's going to be for a particular person. Can you contrast this with some other situations that you might deal with where you do know the likelihood of an adverse event and how severe that will be for that particular patient, just so we've got a bit of a contrast?
Yeah, well, if we're talking about anticoagulation, for example,
Mm-hmm.
which is essentially for people with atrial fibrillation, then we have a pretty good idea of the ballpark figure for how many people are going to bleed as a result of anticoagulation, including deaths. So how many you put them on an anticoagulation to prevent stroke and atrial fibrillation, but a certain proportion are going to have a fatal gastrointestinal bleed or a fatal brain bleed. And that's part of the informed consent process. And
Mm-hmm.
you can't obviously say it for an individual, but you can give at least the ballpark, and you can explain to people that, look, this is unfortunately this is something that may occur. So we know it's severe, and we've a rough idea how often it's going to occur. But that's in the context of an intervention. Whereas if the intervention is going to be swallow or don't swallow, then that doesn't work, because it's all about modifiable risk factors. And we're back to, again, risk of pneumonia. That's not a risk, or it's not a risk of eating and drinking. It's simply something that occurs in people's lives. So there's never much point in saying to people, you might get pneumonia. Well, okay, that's okay. But why are you telling me this? In what context? Do you mean if I change my diet, I'll reduce my risk? Well, you've been unable to show that, and that's not what the evidence points us to. And I guess the one you can, purely because it's common sense, is uh, if you keep the food size small, you're much less likely to choke to death. But that's a very specific one, and that's not the same as aspiration. All pneumonia is aspiration, and it's important to separate pneumonitis, which is chemical, as when you aspirate GI contents, which are very acidic, and that leads to acute adult respiratory distress syndrome, as a disaster in, say, anesthesia. So that's very specific. But in terms of pneumonia, all we know is pneumonia is common, and it's due to bugs. It's due to bacteria in most cases, and those bacteria have come from the oropharynx. So you're trying to say, well, that one was due to that's due to the milk you aspirated yesterday, but that one is due to saliva you aspirated last night. There is no, it's simply unknowable. And we're down to, if you're going to suggest modifying diet as a preventative measure, show me the money, as they say. So based on what evidence?
You've touched on this as well, and I'm not sure how much of this conversation was happening back in 2021. I think it was still being talked about a lot, or maybe it was emerging a little bit more. But I can say that at the moment, there is lots of conversations happening around the risk of having thickened fluids. Whereas I know that when I graduated 15 odd years ago, we weren't talking about the risks of thickened fluids. Thickened fluids were seen as a great sort of intervention, an effective intervention, the be all and end all really for our clients who are aspirating on thin. But can you explain, I think you touched on it, in terms of what some of the research is saying about the dangers of potentially aspirating thickened fluids, or just the dangers in general of going on thickened fluids rather than thin fluids?
Yeah, it's just, and it seems logical, doesn't it? If you aspirate thickened material like wallpaper paste, it's going to be much harder to clear from your lungs than aspirating water or a thin fluid. The one from animal experiments has been really striking, and it's rabbit work, because for some reason the rabbit lung is a traditional route of exploring the impact on the human lung. But if you give thickened material in the adult lung, you cause hemorrhages, you cause much more severe pneumonia and damage than thin material. And a lot of the rabbits die with the equivalent of what we're giving our patients. And I think if you want to recommend thickened fluids, the basis for doing it is, if a patient prefers the better control from thickened, then that's great. If that's what you want, that's what you take. And we all take thickened fluids. I love a smoothie, as you probably do as well. So as part of a balanced diet, it's whatever gives me pleasure and whatever doesn't cause me distress. And that's the, if you like, that's the metric to use, rather than thickened is good. The other one is, if you want to recommend something like that, then you do it in terms of informed consent. You don't say, you must do this. This is safest. We know this is safer. You said, instead, it's, you might like to try this and see, does that make you feel better? You might like to try it is absolutely fine. And people might try and say, no, yuck. No, that's fine. Yeah. And what you don't do then is say, well, I have a bit of paper because you are now officially risk feeding, and our policy is you're only allowed to do this if it's in triplicate and witness signature. Please, no, don't. If somebody doesn't like it, then you've no evidence base to go any further and saying you might like to try this. If somebody has type 1 diabetes and you're recommending insulin, well, then you're saying you must take this or you're going to die. the implication be you'd be a total fool not to take this. You must have some kind of a death wish. Endocrinologists are allowed to say that kind of stuff. And
Yeah.
endocrinologists say, well, if you're refusing insulin in type 1, you're going to be dead within a fortnight. Now I have serious concerns about your capacity to make that decision, perhaps. So it's a totally different ballpark from recommending thickened fluids and saying, well, we've no real evidence of benefit and might do more harm, but do you want to try this and see does it feel better to you? And again, you're handing the decision back to the patient. And if they say, well, do you know, I like the slightly better control of thickened material, that's fine. Up to you. And if you change your mind 2 days later, that's up to you too.
And I think in the community, I think it's particularly tricky as opposed to, in a hospital, it's, you've got the whole sort of team there. I'm sure there's structure and policies in place. But when you're out in the community, what I found particularly difficult and what my colleagues found particularly difficult were our clients with developmental disabilities and intellectual disabilities who were in supported accommodation, so group accommodation, because all of those providers had sort of the same policy in that they were only allowed to give these residents food or fluids that was outlined in the mealtime management plan that was written by a speech pathologist. And so then that puts us in a position where we're apparently in control of, recommending, certain food and fluids to these particular clients. And a lot of these clients as well, being older, having a disability, they don't necessarily have next of kin to be making these decisions. So I found that has been a particularly tricky area to navigate.
Well, I think there's an education role there, Chantel, of saying, if you write something down, that you write it down and say, by the way, we've no evidence thickened fluid works. So if they want thin fluids, give it to them. And of course, if somebody has an intellectual disability and every time they drink, they're drinking, like in the old Coke ads, glug, 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 and they're waterboarding themselves effectively. Well, you can put in guidelines around that. But in terms of writing out this fixed meal plan, remember, I'm qualified quite a long time. That is only crept in the last 2 decades or so. There was none of this 20 years ago, and we were better off to the extent that staff in the units used common sense. They didn't use thickeners. And of course, they didn't go giving somebody who has no teeth, giving them a big lump of steak and walking away. That just never happened. And if somebody was drinking water and was clearly massively distressed by it because they'd forgotten their distress, well, then you give them small amounts at one time and make sure they're upright while taking it. So there's a lot of common sense measures, but if you've taken upon yourselves, which you have as a specialty, to write these fixed plans, well, then you've increased the anxiety levels of people in residential care facilities. Just don't write rigid plans that say you must take this. Instead, you say they may find this better, they may not. Don't get hung up on it. But I think that writing out these plans as though it's the Bible has, the book of Genesis and must not be deviated from. If they cough or a drop goes down the wrong way, my God, it's a disaster. Their lungs are going to die tomorrow. I mean, that's where we're at, unfortunately. And everybody's anxiety is higher and nobody's outcomes are better. So it's going to be a hard job to reverse it. But I think stop writing unsafe swallow, for example.
Yes. Yeah, I wanted to ask you about that as well. I think you mentioned in your paper that, that term unsafe swallow, it's arbitrary. Can you explain what you mean by that?
Well, what I mean is if you've problems eating and drinking and you've swallowing problems, well, then you're swallowing problems. Saliva will go down the wrong way. It's coming into dragging it into food and fluids, saying it's an unsafe swallow. Therefore, there must be all of these dietary restrictions. A lot of them are based as well on swallow studies, which are absolutely fine sometimes in terms of telling you where the problem is.
Yep.
But in terms of saying that based on this video fluoroscopy study, you have an unsafe swallow on all Cs. So where does that get you? Because again, the implication is you have an unsafe swallow that we will make safe by our interventions. Well, Again, show me the money. The idea of unsafe swallow inexorably leads to people being nil by mouth. You've an unsafe swallow. That affects food and fluid. We can't let you eat and drink unless the speech and language therapist signs you off, which has led you into risk feeding policies. So it's self-perpetuating in terms of, if you like, the risk in risk feeding is the risk to the professional. This is risky for me. I'll be blamed. And I feel there's a lot of that in terms of the policies. It's to allay professional anxieties rather than to actually benefit the person.
Yeah, 100%. I agree. I think as a field that we tend to be quite risk averse, and like I said, we sort of come out from training with this fear in us already. And I think what I feel like is happening in the field of dysphagia at the moment is I think things are changing massively. If I think about the way we practiced and what I was taught, 15 years ago, I think it's very different to what I'm seeing now in the conversations that we're now having. And I think the tricky part as well is that, you know, we're a relatively new profession. I don't know the exact decade when we popped up. I think it was in the 50s. But in terms of dysphagia coming into our scope of practice, I don't think that happened until the 90s. So we
Yeah.
were doing things and, providing treatments and interventions before we had the evidence for it. And now evidence is coming out, and I think we're kind of backtracking a little bit and realizing that perhaps the things that we've been recommending weren't as beneficial as we thought.
I think that's very, very true, Chantel. I'm seeing it, because the paper we're discussing and the other ones I've written have been with colleagues, a lot of them speech and language therapists. So there's been what's called the backlash publications in some brigades. And I think it's interesting. Arlene McCurtain, my friend and colleague and co-writer on the paper, has a whole series of articles saying, why do we do this stuff? And a lot of it is, this is the way we've always done it. This is how we do it here. And what I'm seeing with colleagues in academic speech and language therapists is a lot of the academic teaching is actually changed. They're highlighting the lack of evidence, they're highlighting the downside, but talking to them, they say, well, we send them out from our course with a healthy skepticism about thickened fluids and knowledge about this is not the panacea for everything, but they end up in clinical practice where they're told, well, this is what we always do in this department, and they fit in with that practice. The one I found very positive is there's been a whole series of publications now. We're just one, but I'm delighted to be in the vanguard. But I see the Royal College of Speech and Language Therapists position paper really changed direction entirely. It's rolled back very considerably on what had been the previous policy. So I think it's a positive and a change, but it's slow getting through because current practice has become so ingrained. We're going to be a long time getting rid of it. But you're right, the practice developed without the evidence. And now I get that feeling of disorientation. Where are we? What do we do now? The problem is you've taken on the role of saying, we're the people that prevent pneumonia. The way to prevent pneumonia is by doing what we say, listening to our recommendations about safe swallows and modifying the texture of diets. And how do we get out of this quandary? And I'm sorry for people, but it's one you've made for yourselves.
It's not the first time that I've heard that either. I've heard other speech pathologists and academics sort of mention the same thing. We've kind of done this to ourselves, and we're trying to backtrack a little bit more. Earlier on, we've talked about how important it is this person has, thickened fluids and whatnot, and now we're like, well, okay, we don't actually think it's that effective. So, yeah.
Yeah, no, but that's a kind of internal conversation, whereas it hasn't got through to the rest, and that's where really to say, please don't be sending out the Bible from the hospital when you know it's not the Bible. And if you send it out, in fairness to, say, nurse and residential care facilities, this isn't their territory. And they're being told it's the Bible. Don't tell them it's the Bible. Absolutely put everything there couched in maybe, perhaps, whatever. But something you did say earlier is, how did I end up here? I'm a geriatrician. I have no interest in swallow. Zero, or at least zero, until about a decade ago. My interest has been in consent and that territory kind of lead for the Irish Health Service on areas related to consent. But my interest came to a single patient. I also did the elder abuse and elder neglect work in the west of Ireland. And my interest in this stems to a single patient where I got a call about somebody who'd been a patient of mine, a lady who'd had a severe stroke, had been in my rehab unit for a few months, had aphasia, had difficulty swallowing, went home to a very dedicated husband with the full setup, a big package of care, hospital bed, tube feeding, a lot of training, and went out. And this is about 2 years later, and the call came from the community to say that everybody's very anxious in the community. The husband is feeding her. He's been told she's nil by mouth because her swallow is unsafe. And now he's given her ice cream, and he's given her wine, and he's given her water, and he's given her all kinds of stuff. I'm saying, this is terrible. He's going to kill her. He won't listen to us. We've told him this is dangerous. What do we do? We might have to take her into care and put her in a home because the husband is at risk of killing her. And I was kind of red flags were going off my head. This was a devoted husband. First of all, he certainly wasn't going to do harm to his wife. And everybody was so certain. And I said, well, how is she? And they said, oh, she's okay. So, right, what's the enormous harm happening? Well, they went, she'll aspirate. Aspirate, that's a death sentence. How would you do that? And again, it was nothing to do with speech and language therapy. So I went out to see this lady, and she was looking great and well groomed, which is always a good sign. The hair was done. Looked at the mouth. The mouth was lovely and clean. She looked happy. And the husband was there, embarrassed, humiliated, frightened with the threats that his wife has been taken away with him. And he gave her a drop of tea. She coughed a bit, and she couldn't speak, but she signaled more tea. He gave her more tea. She coughed a bit, and so what's all this about? Everybody was so certain that this was dangerous, neglectful, a nuclear option of taking her away, and go. And that's when I said, but where does all this come from? How are people so certain that giving her tea and giving her wine? She liked her wine. This lady had this very severe stroke. Her life expectancy was going to be reduced. Give her as much wine as she'd like. Could be mine. Give her ice cream. Give her high quality ice cream. So I just, and that's where I started reading. And when I started reading and started looking for, oh yeah, I'll get a good review article now about the benefits of thickened fluids and nil by mouth. But how come I'm not finding any articles on this? It's all, and I started digging, and that led to my first publication in 2018 saying, and it took ages to write because I kept saying, I'm missing something. There is some article somewhere, some study that's going to explain to me how this has become the standard of care. And I could never find it. I never did find it. Haven't found it since. Haven't seen it since. And there's no registered trial that's going to answer all this. So that's where I started out.
Thanks for sharing that, Shaun, and thank you for being a guest. It was great to hear your perspective, and it's been a really informative discussion. Thanks for tuning in to the Dysphagia Research Bites podcast. If you want more dysphagia education, then head over to Instagram at Dysphagia Community or www.dysphagiabites.com. Bye-bye. I stuffed up my chopsticks.
One thing that you